Thank you very much, Victor. Good morning, everyone. Great to see all of you. A terrific introduction by both Marc and Victor to what I think will be a terrific series of discussions this morning. We're going to count on all of you to fully participate. Each of our speakers are going to give some comments, and I'm going to ask them a few questions, but then really turn it over to the audience to probe the areas that we're going to be touching on. As Victor has suggested, this is really the beginning of a process of getting comments on the thoughts of others as we've put these papers together, and hopefully reflecting the broad range of views that I know, in fact, will be obvious during the course of our discussion. Not surprisingly, the desire for effective, efficient, and affordable care is, without question, at the heart of much of the legislation that has been considered in recent years, much experimentation that has occurred, and the focus of both public and private efforts. Hence, this mixture of public and private participants in our discussion this morning. The 8 papers that we are including in this section examine many of the components that are critical to achieving all of these goals. Among them, benefit design, payment strategies, precision medicine, workforce challenges, care coordination, and the need for transparency and the democratization of healthcare. No one of these issues is easily solved, nor any of the solutions without a certain amount of risk. Can we, for example, redesign the Medicare program or other coverage to promote value without putting at risk poor decision-making and essentially leaving people underinsured? Can we organize to promote population health, to treat acute healthcare issues, to deliver care to those chronically ill or to those who are at the end of life or nearing the end of life, something near and dear to a number of us in the audience? Do our financing models encourage the right kind of delivery system, the right kind of incentives, and the challenges that each of those models present to us in designing these systems? And do, frankly, the necessary teams exist? Victor pointed out at the end of his comments the real challenges we have with respect to workforce. Are we, in fact, preparing our nurses and our physicians and others to care for people going forward, but to really participate in the delivery systems as they transition? And do we, in fact, have the right workforce mix? Are we, in fact, looking broadly at what the services are that people require that perhaps are outside of what we have traditionally viewed as the healthcare system? And incorporating some of what Marc suggested in terms of social welfare system that allow people to stay at home, that allow people to be able to manage themselves without having to be admitted to an acute care facility. So all of these questions are questions that we have examined and thought about. One of the things that we propose, of course, as part of all of that is transparency. And that is the transparent information that's available to providers, to organizations as we move forward, but also importantly to the public and to, in fact, consumers. It's important, but is it working? What are the risks in terms of transparency? And among all of these issues are the issues that we are going to touch on today. Among the themes that are in fact touched on in the 8 papers that are within the purview of this discussion are the importance of continued experimentation and research, something that Rick certainly knows a great deal about, having spent time at CMS and looking at how we in fact look at these questions and how we examine them. The value and the complexity of information, how we gather it, from whom we gather it, how relevant it is, and how valid and accurate it is. Both the public and private sectors clearly have a role. Now both Rick and Lou can comment on what they view as that public-private sector intersection. And I'm hoping Peter will talk a little bit about what in fact should that balance be. How, in fact, should we balance that going forward? And frankly, the vital role of patients and consumers in designing these systems going forward. And I'm hoping that Marc will help us think about what they need to know and how best to think about that going forward. My panel, the collective My Panel, are a remarkable mix of public and private sector experience, deep knowledge of essentially the system and what in fact is taking place and how these innovations are putting forward some options for us to think about and for the new administration to think about. Very briefly, I will introduce each of them. Marc is with the National Healthcare Council that brings together segments of the health community and looking at these issues and provides a united voice for about 133 million people with chronic diseases and disabilities and family caregivers, another important component to the answers to the questions before us. Rick Gilfillan is the president and CEO of Trinity Health and in 2010 became the first director of the Center for Medicare and Medicaid Innovation. So Rick has had a hand in helping us think about how we design questions going forward and how we design some of these systems that we're testing out. Peter Orszag is the managing director and vice chairman of investment banking at Lazard, but is also at Brookings. But importantly to our purposes today, was director of the Office of Management and Budget and also the director of the Congressional Budget Office. At the heart of a lot of what takes place is the estimating and the costs. Does it save? Does it not? What do we really understand about these interventions? And from the congressional standpoint, it's all about scoring. And Peter can certainly talk to us about the vagaries of scoring, sort of the Masonic mystery of how some of these numbers come to life, which certainly left us at the Finance Committee guessing, not infrequently. And Lou Sandy is with us, who is the Executive Vice President in Clinical Advancement at United Healthcare. At United, he is focused on clinical innovation. He looks at payment and delivery system reforms, and really as physician collaboration and how we equip physicians to essentially make many of these decisions. And so again, I think we have this wonderful mix of public and private sector to help advise us going forward. I've asked each of our panelists to speak briefly. To begin, I've asked each of them to think about and perhaps identify for us what they think the main themes were of the 8 papers that are before us, and what message do they think is most important for us to think about and talk about this morning. So I'll ask each of them to do that, and then I'm going to ask each of them to think about what they would do if they had 5 minutes with the new president and his advisors in terms of what issues should they take on in the first 100 days, 200 days. What should be, in fact, the priorities of a new administration and looking at the jumble of issues that we have to contend with. So I'm going to begin with Marc to tell us what he thinks the main themes are and what messages, 2 or 3, that we ought to take out of the papers before us. Marc.
Thank you, Sheila, and thank you for the opportunity to be here. I want to thank NAS for not only including me in this panel and including patients, family caregivers, patient advocates throughout the process here as authors and participants, but to really think through what has often been a missing link. When I think of the theme that is most important when I look through these papers, it's the theme of the concept of patient centricity and how it's beginning to mature. Patient centricity is something we've been talking about for a long time. And I run into experts all the time who say, I put the patient first in everything I do. I think about them, and I look to do what is best for them in all my activities. That is not patient centricity. That is paternalism. And that has characterized our healthcare system for many, many decades. Patient centricity is more than thinking about what's important to the patient and their family caregivers. It's about engaging them, understanding what's important to them, looking for the cues that go beyond simple health. It's understanding their information and then utilizing that information to design and deliver health. That is very different than having good intentions. And I don't deny for a moment that everybody I have dealt with in health has really good intentions. But I became a patient advocate more than 25 years ago because I saw so many people in my family stricken with chronic disease and disability. I watched them deal with autoimmune, neurologic, cancer, autoimmune, rare. I watched a lot of them deal without effective treatments, and I watched a lot of them deal with a delivery system that was not aligned with what was important to them. And I watched most of them die over a relatively short period of time. And I've devoted my professional advocacy career to ensure that we truly and meaningfully, in a scientific, reliable, representative way, engage the end user in how we design and deliver care and how we develop new treatments. When you look across the papers, there are elements of this throughout. And I've seen a huge evolution in just the last decade. And I want to describe it in the context we use in the patient community and then highlight one area that I think is missing or not well addressed in the papers. We in the patient community think of this in what we call the chronic care trifecta. So I'm curious in the audience, how many people know what a trifecta is? I see a few hands. I always get a kick out of asking that question because people are a little reluctant to raise their hands. A trifecta means you pick the top 3 horses in the right order, and if you do that, you win big at the horse races. I'm here to tell you from the perspective of people with chronic conditions, 133 million of them in the United States, and a subset of that population is driving the vast majority of costs in our delivery system. View this in 3 discrete parts. We want to have treatments that are safe and efficacious. That's a given. But that's only a part of what we want. We're looking for treatments that are going to work, but they have to work in the context of where we are. And that's where the social determinants of health, behavioral issues, and the environment play a huge role. We live our lives in a context. Once we're diagnosed with one or more chronic diseases, we're not just a disease. We're not something just to treat. You have to come at us and deal with us in the context you find us. And you see a lot of references to that throughout the papers. So having a clinically effective treatment delivered in the context that you find us, given all the different determinants that are impacting our daily lives, critically important. But there's a third part to get the trifecta right for these complex, high-touch, high-cost patients. And that is, you have to understand what their goals are. If you forget about what they're trying to achieve and treat them as a disease, you may very well be throwing a lot of money, a lot of good care that is clinically sound, but completely irrelevant to what's important to that patient. And I want to drive it home by giving you a couple of very quick examples. Think of 2 people with Parkinson's. And imagine that they're expressing the disease in the same way, which rarely happens given the variety and challenges with that disease. But imagine it is, and they both go into the medical system and they get the best care and they get the standard of care. That might be completely irrelevant to what's important to them. Imagine one of those gentlemen is concerned about keeping their partner awake at night due to the tremors and wants to be able to sleep without causing disruption to that family unit. Imagine the other person is up for a promotion and doesn't want his or her employer to know that they have a disease. Knowing those goals would allow you to tailor a treatment for each of them that would be different, not standard of care. And yet we rarely ask people who are high-touch, complex patients what their goals are. From our perspective, to get the chronic care trifecta right, it's provide good, sound medicine in the context of where we are, our personal circumstances, but it has to be relevant and aligned with our goals. One other quick example is a real story of a woman in Baltimore who had diabetes and heart disease. She was being treated and given absolutely the first-class care. And yet, she wasn't being compliant, she wasn't being adherent, she'd be scolded every time she went into the doctor's office. Nobody took the time to figure out what was important to her. Turned out she was a single mom with 2 children, one in high school, one in college. She was living to make sure her 2 daughters did not become single mothers like her without an education. And she was going to do everything in her power to make sure they got good educations and did well. The treatment regimen she was on made her lightheaded and dizzy. And you might say, well, you know what? It was still the best care for her. The reality was she drove a bus. There was no way she could be compliant or adherent under those circumstances and meet what were her priorities in life. Designing care around the individual with what is most clinically effective relative to their personal circumstances in the context of their goals. And that's the piece I didn't see enough in the papers. But I will tell you, I've seen a huge maturation in the concept of patient centricity, moving from good intentions to let's figure out how to engage patients in a meaningful way to understand what's important to them. Because at the end of the day, these high-touch patients that are driving costs are utilizing the system to meet their goals. They're not utilizing the system to get good blood sugar ratings. They're using the system to achieve their goals. I'll stop there.
Good. Thank you, Marc. Lou.
Well, thanks, Sheila, and good morning, everybody. As was mentioned, I've been on the steering committee for this effort, and I also was a co-author of one of the papers in this series, the Austin Pronovost paper on transparency in outcomes. You know, when I first got involved in this, it reminded me, many of you, I'm sure, have been in various meetings in health policy topics, and at some point I always find in a meeting, things tend to kind of globalize and diverge, and I say something like, look, we're not here to solve every problem in health and healthcare. We're here to work on this. But when Marc invited me, my first thought was, oh, are we really going to work on every problem in health and healthcare? But I think that what has come out of this so far, and your input will be tremendously valuable, I look at it as holistic, but also focused and prioritized. And I think that both of those are really essential in trying to make progress at this stage. In terms of the papers in this series, there were 8 papers, and when I read them all, I came up with 5 themes. The first, theme 1, is there was actually absolute consensus, and both Marc and Victor mentioned this too, absolute consensus on the magnitude of the issue and the availability of the opportunity. The magnitude is huge. About 30% of all health spending is wasted. And it's not as if we can't realize this, and I'll get into that in a minute. So all the papers essentially had an optimistic approach. Theme 2 was the issue of quality measurement, transparency, data, the need to free the data to kind of have a data-driven improvement capability. Because that, in my view, is fundamental to every other strategy that the papers, and even the ones outside this series, focused on. So that was theme 2, data, quality measurement, metrics, freeing the data to be able to do that. The third one was the crucial role of benefit design and payment policy. It's an area that I work quite a bit in. I'm not going to comment. I'm sure we'll get into it in discussion, but it is absolutely crucial to incentivize what it is that you want. If you incentivize volume, you're going to get volume. And if you incentivize value, we will get value. So we'll get into that. Theme 4 was the issue of new competencies and new relationships. To do this, we're going to have to do things differently and work together in different ways, and including in the term workforce, and Marc mentioned this too, patients and families. They are part of the workforce, an untapped, tremendously untapped resource. Working with them in new and different ways, I think, is one theme that cut across many of the different papers. And then the fifth theme was that I thought two of the papers were particularly disruptive, and I just thought I'd share this with you for your reaction. The first one was on precision medicine, because many of the things that we touch on, including the paper that I worked on and others, we actually know how to do these things. We can identify best practices, and our big challenge in high-performing healthcare is that we haven't spread the best practices, we haven't scaled them in an efficient, effective way. We kind of know what to do, we just haven't spread how to do it. But precision medicine is different. Precision medicine is something that we actually don't know how to do at scale. It's an exercise, to my mind, in data-driven discovery and application. Tremendously exciting, and we'll have a whole panel on it, but I'm not aware that anyone really knows how to incorporate genomic information, the microbiome data into customizing care for somebody's weight management and diabetes. No one knows how to do that. So that's a very exciting invention and disruptive force that I think all of us are going to be both experiencing and hopefully benefiting from as patients. And then the second one is the democratization of healthcare, which flips the relationships in fundamentally different ways. And I think the most radical idea in the series of papers is to focus on patients and families for real, not the lip service that healthcare delivery systems and financing systems tend to do. And enabled by social media, enabled by demographic change, enabled by the growth of chronic illness, and prompted by the issues of disparities and the lack of health equity in the country. That's probably among the most radical in these papers, and I think if we really took it seriously and took the challenge of taking and building our systems for value according to how patients and families look at it, that would be very disruptive and in a very positive way. I think the workforce paper touched on that as well. So those are the 5 themes that I came away from these. And again, the spirit of optimism, possibility, and the timing is right to start to begin to actualize these.
Thank you. Rick.
Excuse me. Well, thank you, Sheila, and thank you, Victor and Michael, for having us here. I think Lou did a great job of laying out the themes that came through the papers, and I would agree with you, and I would agree with Marc about the perspective and the need for us to learn more about what it means to be a patient or people-centered, as we refer to it. I'd like to focus on one theme, which is in many ways, I think there are actually two prerequisites to change. One is, I believe, the marketplace, and the other is the provider mindset that we have. And I think for a moment I'd ask the question, why do we have a healthcare system that not only doesn't deliver great outcomes, but steals 7-8% of GDP and wastes it? Like, what's that about? You know, if you really dig deep and say why, I'd suggest that there's at least 2 underlying drivers. One is the marketplace, and we all have talked about having an ineffective marketplace for value. But the other side is, at a more granular level, is about providers. And I'll leave aside the payer side for a moment, Lou, and not speculate on that. I've been in that boat, but that's yours for today. But providers, why do providers act in a way that steals 7-8% of our economy and uses it ineffectively? And by the way, it's interesting, Marc, I love your slide, and I gotta get a copy of the one that shows, you know, all the mix of medical and social spending. And I was sitting at dinner next to the head of a very large, prominent, absolutely world-class healthcare system in this country, and a smart man. And he cited the top line and said, well, after all, when you add the 2 together, we spend the same as everybody else. So really, there's no problem. And totally missed the point that we're spending it after the fact and not trying to make people healthy. And I believe that that is a fundamental understanding or misunderstanding or gap in knowledge for healthcare providers, because we tend to see our world right in front of us. So for today, for this conversation, I'd ask you to think of me as someone who, we deliver 1.5% of a lot of healthcare in America. So 1.5% of the babies, about the same amount of cardiac care, about the same of joint replacements, right? And you can say and ask me, well, why aren't you delivering high-value care? What's with that? What's that about? If you really dig deep, what's going on that's resulting in that number? Because that number is a point figure that represents the vector force of about 200,000 healthcare people, 2 million healthcare people, 700,000 doctors, millions of nurses, et cetera. All the things they do every day, the way they go about their business, it becomes a vector force that drives to that consumption of 17% of GDP. And so we have to back up and say, what is it? What's in the provider mind that leads them to do that, right? And how do we change it? One way, I would suggest that, going back to the conversation I had with that CEO, there's no conceptualization of how much we're using, because we're responding to microenvironments that we live in that put demands on us. And today, we talk about transforming healthcare, but if you're sitting where I'm sitting, or where one of the 20 CEOs of our regional health entities are sitting, you don't have one transformation. You got 7 or 8, right? You've got, yes, we want to change the way we get paid, right? We want to change the way we deliver care. We want to be more people-centered. We want to take incentives related to value. We've got a democratization in the marketplace, and we've got transparency. We're transforming the very physiologic approach to care when we talk about precision medicine. Totally different from giving everybody the same chemo. We're going to now target chemo based on a whole new series of very expensive tests. Oh, by the way, we're transforming our IT infrastructure, not just once, as we just did by putting EMRs in place and created giant legacy, big iron EMR systems. And now we're looking at creating apps using a whole different approach to development, architecture, code, people in IT. So we're transforming for the second time in the last 10 years our IT infrastructure. We're transforming a workforce, and we're dealing with physicians who are grieving about the lack of status, the loss of status, their change in a democratized, people-centered world. They want to know why it isn't a physician-centered world. And we've got nurses who are feeling challenged as well. So we're transforming the workforce. And lastly, we're transforming the very architecture of healthcare organizations. What were discrete individual units that could operate with duplicate infrastructure and administrative capabilities, we're now centralizing into larger systems, and because we have to become more efficient. And so we're changing that architecture, changing the job of those 20 regional CEOs. Oh, and by the way, please take care of 100,000 people in your emergency room at any hour of the day or night. Deal with labor issues, and transform your fundamental way of delivering care. And yet, right now, it's not transformed. So right now, value-based approaches are competing for mind share in CEO, healthcare executives who are trying to cope with all that other stuff. And so the question becomes, as we think about ACOs, for instance, or bundle payment, it's not a simple question of sitting in DC and saying, I think from a policy standpoint, this is the right thing, or I need to put all providers at risk, because then they'll really care and they'll transform everything. The real question is, in a voluntary world, how do you construct programs that take people who mean well, who want to do the right thing, but who are preoccupied with filling beds or seeing more and more patients or providing more and more services? How do you engage them in a way that allows them to gradually shift their mindset from that to one that really starts looking at the triple aim of better health, better care, and lower costs? That's a very different question, and in DC we tend to revert rapidly to simple solutions. put everybody at risk. And this is CMS's current strategy. And I think we're at a crossroads. I think it's important for us to start thinking more deeply about the reality of what this transformation really is and what it will take and how we should go about in a respectful way. And by the way, I have to say here that my friend Chris Daw, who worked in Senate Finance and did a lot of work with Sheila and others, right, always reminds me about coming to town and being a whiny provider. I hope I'm not being that. But the reality is we are out there caring for you and caring for your families. And it's hard work. And you want us to do all this other change. We need to figure out from a policy standpoint here in this town how to do that, how to engage people in a way that allows them to take their best instincts. Everybody wants to deliver better health and better care and lower costs. Nobody wants to be stealing 7% of GDP and wasting it. But we need to figure out, we need to revisit how to do that and how to integrate that with the issue of people-centeredness and marketplaces that actually are another driver of us producing those services. And I think that, to me, is a big theme in the papers. It's in the payment paper. It's in the capabilities paper. By the way, you need a lot of new capabilities to deliver this care. And they don't occur overnight. DRGs, when they first implemented, in the first 5 years, resulted in a decrease in length of stay of 10%. Over the next 15 years, it resulted in a decreased length of stay of 35%. That's a mandatory must-do program. And here we are 3 years into the ACO program saying, oh my goodness, we got to push everybody to risk because it's not delivering enough savings in a voluntary world. So we need to step back, take a look at, I think, what's going on, how people are trying to make progress, and consciously engage people in a much more strategic way rather than a simple policy fix kind of way, so that we can continue on a gradual basis to drive the kind of improvement we have seen, which is, as Marc pointed out, we've seen improvement. We've seen trend go down. Providers are thinking differently, but they're not at the point of totally changing their mindset. So it's about provider mind share, not risk share. Thanks.
Thank you. Peter.
Well, let me, I want to get back to the main themes, but let me just, I hope we do have time to get into this question, because I guess I'm going to part company a little bit and just say I am skeptical that a voluntary approach is going to pay dividends over the long term, in part because when it's voluntary, almost by necessity, you need to make the incentives pretty weak to get participation, and therefore it should not be surprising that you don't get phenomenal results with weak incentives, but we can talk through that. In terms of the themes, I think the broad one that was already mentioned is just the possibility here. I mean, who among us would not want to have the healthcare that we all believe is going to be present in 10 or 15 years relative to the healthcare that was available 10 or 20 years ago? I think it's just an extremely exciting time, both from a delivery system reform perspective and from health science perspective in terms of just massive advances. But that highlights one of the themes that's touched upon or was the focus of one of the papers that I really think deserves a lot more attention, which is the growing gradient in life expectancy. Marc mentioned it. I co-chaired a National Academy's report with Ron Lee on this topic, and so I just want to flesh this out a little bit, because I think this is the next, we've heard a lot about income inequality in the policy world. I believe this is the next frontier in the inequality debate. It is astonishing that we live in a country where at the bottom of the earnings and income and education distribution, life expectancy is flat to down. That really should not be happening. If you look at the gap between the top 20% of earners and the bottom 20% of earners for men born in 1930 who make it to age 50, the gap projected to be 5 years. 1960 birth cohort projected to be 13 years. So in demographic terms, over 3 decades, to move by 8 years, this is not a slow tectonic plate kind of shift. This is massive, rapid change that's happening. So then the question becomes, are we absolutely sure about the results? And I would mention just 2 caveats before we kind of get too far ahead of ourselves on this, because there has been a variety of research showing these increased gaps. I think my opinion is it is compelling, But there are two things to be wary of. One is there is new research showing that at the county level, not at the individual level, low-income counties, if you look at life expectancy at birth instead of at age 40 or 50, actually experience, if anything, a slightly more rapid increase in life expectancy when measured at birth as opposed to age 50. Now that was at the county level, not at the individual level, but the county level data from age 40 or 50 on is consistent with the individual level data. So that's sort of an interesting puzzle. And then the second thing that Marc, the paper that Marc cited went into more detail on is you just see dramatically different gaps or trend, gradients in different parts of the country. So it is ironically better to be a low-income person in New York City in terms of your life expectancy than it is to be a low-income person in West Virginia. And the question is, why is that? Because a lot of the other potential explanations, income inequality, social stress, what have you, presumably would, you could make the argument would be worse if you're a low-income person living in a high-income area where the norms are set by the people around you. There's something else that's potentially going on. I would also note that this is having massive effects on our public entitlement programs. So that National Academy's report that I co-chaired with Ron Lee documented, and it's not surprising, look, if a high-income person is increasingly living longer relative to the median or the 10th percentile, that means that they're also getting their Social Security benefits for a disproportionately longer number of years. And same thing for Medicare. So all of these major entitlement programs are becoming substantially less progressive on a lifetime basis because of the differential mortality, I think, which also highlights the question of what is causing this. And we have a variety of explanations out there, but the fact of the matter is most of it is unexplained. So when you try to document, differential trends in smoking, smoking's collapsed at the top, it's come down less rapidly at the bottom of the socioeconomic distribution, so on and so forth, you can only explain something like a quarter to a third of the increased gradient. So there's a big missing piece, which most likely has to do with some form of stress or social determinants or economic environment, but it's a missing, big question mark. And I think to get a handle on what we should do about this problem, we'll call it that, a problem, we need a much deeper understanding of what the underlying drivers are so that we have some sense of, and you have, again, some clues from the variation in the United States. It's encouraging that there are some places that are doing much better. New York is a good example, and maybe lessons that can be learned, but we still really do not have our hands around exactly what's driving that phenomenon.
Thank you, Peter. We could clearly go on for many hours on any one of these topics, but I'm going to ask each of you now to tell me what you would say in your elevator speech to the new administration or to their senior folks. And Peter, I'm going to begin with you.
Okay. So I would highlight four things. The first is the need, and I guess we have to, this will depend on which administration we're talking to.
There is that.
And what the
there is that. Let's put that reality aside for a moment.
I mean, the first thing is there clearly are issues on the exchanges that do require attention. Unfortunately, in my opinion, they require legislative fixes. So depending on the configuration, that may or may not be a fruitful discussion point. But things like extending the reinsurance program and extending the risk corridor, taking steps like some states have to dial back the individual coverage that is off exchange, that is purchased not through the exchanges. There are a whole variety of things that one could do to try to shore up the public exchanges, and I do think that's important to do. We could talk more about that. The second thing, which is related, which is a longer-term 4 to 8 year project, is underlying a huge amount of the healthcare system in the United States is a structure of really poorly designed risk adjustment that pervades Medicare Advantage, it pervades the public exchanges, it's basically pervasive. And the HCC risk adjuster that CMS uses, which is claims-based, can explain only like 10 to 15% of the 1 year ahead variation in cost. It does a very bad job. As the system digitizes and we have more clinical data that are digitally available, you can do a lot better using clinical data. The risk adjusters that use clinical data can get that 10 to 15% R squared up to something like 50%. It's not surprising because the claims data will tell you that someone had a heart attack, was admitted to the hospital, and then was discharged. It won't have cholesterol, blood pressure, blah, 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 all the other things that you'd want to know. Here's the big challenge that I think administration could start working on. No one is going to want to turn over their clinical data to the federal government in order to do risk adjustment. But as medical homes and as ACOs and all these other places develop so that you actually have a fair amount of clinical data about a person, enough sufficient to have a good picture of them, it is worth considering, and I put this out as an idea that is still not fully fleshed out, whether the federal government could design algorithms to run on that clinical data without owning the data. In other words, we send the algorithm over, it runs on the clinical data, and out comes a risk score. We all have credit scores. We all should have an individualized, clinically driven risk score, maybe more than one if we want to have some competition. That's fine. We have that on credit scores also. But the point is we could do a lot better in this. This is one of those foundational problems that if we don't fix, pervades lots of other issues, including the exchanges, by the way. Mm-hmm. All the debates about age bands and what have you, if we had really good risk adjusters, would become much less important. Third thing is that we do need to go further down the road on payment reform, and this comes back to the debate about the discussion about the path forward. It's my opinion, and we can have a longer discussion about this, that we do need more mandatory alternative payment mechanisms, and that the way to do that is not, you can't make an ACO structure mandatory at this point. It's far too much of a jump. So the way to do it with the appropriate amount of humility and care is to cascade out more mandatory bundles as CMS has started to do. Now, I'm fully aware of the discouraging results from last week from BPCI and so on and so forth. I think we can have a longer discussion about exactly what may be causing that, and also that helps to point the path forward towards the episodes that are the most promising for new mandatory bundles, but I would highlight that. And then finally, I would highlight the need to start thinking harder about reforming Medicare Advantage. And in particular, let me highlight this issue. After the ACA was passed, or as part of the ACA debate, the Congressional Budget Office and others, don't forget, we were supposed to experience the death of Medicare Advantage because we cut back on the payment rates. Instead, Medicare Advantage has grown rapidly. It's now roughly a third of Medicare beneficiaries, and plausibly will be half or more, certainly within the next decade. So the reason that this is worth attention now is Medicare Advantage was always was designed to be the tail, not the dog. Even the way that payment mechanisms work with the benchmarks that are based off of fee-for-service Medicare, it doesn't make any sense if those benchmarks are based on a minority, small share of patients. So we've got some fundamental rethinking that needs to go on in Medicare Advantage that could also be used to drive more of the payment reform. That is to say, all of the entities that are involved in Medicare Advantage are themselves trying out different payment models with providers, but most of that information does not then flow back to CMS and to Medicare as a whole, so you have less of a sense of even trying to document which insurance company is doing exactly which payment reforms as part of Medicare Advantage is more challenging than it should be. There's a big agenda here in Medicare that involves Medicare Advantage over time becoming basically the dominant form of Medicare coverage.
You can tell Peter lives in a building with a very long elevator ride. That's what you get in New York, that 60th floor of the Lazard building. Rick.
Yeah, in Detroit we have short buildings, but I spent some time in New York, so I'll be in between, I guess. So great points, Peter. I think fix the marketplace for sure. There's so much there that needs to be done, and it's possible. Risk adjustment, absolutely. The truth is that notwithstanding the adjustments made in ACA, the reality is that Medicare Advantage is still significantly more expensive than fee-for-service. I'm not sure anybody's owning up to exactly what it is at this point, but it's more expensive. The irony of the ACO world, of course, is that CMS is starving ACOs, making the deal as hard as they can be, and forcing ACO providers to say, I'm just in it so I can move people into Medicare Advantage, which will cost the federal government more. So we're actually in this perverse world where policy is driving up expenditures for Medicare, and it's all based on underlying HCC coding, right? Optimizing HCC coding is, by and large, the biggest driver of profitable success in Medicare Advantage these days. So a bit of a perverse situation, but I would agree over time it would be great to do something. I think there's something about negotiating drug prices that needs to be said. What does it take for us to realize how absurd our situation is, and with the genomic medicine or the genomic work that's being done in precision medicine coming down the road, if we don't find a way to get our arms around pricing, we've just created the perfect economic engine to drive the 17% higher and higher. So somewhere we need to find a way to deal with that. Come back to bundles for more conversation. I would say, Madam President.
No preferences shown.
I say that because there's no preference, but we don't know, so one has to go one way or the other, so right? So might as well go for something that's a little different.
It's different either way.
It's going to be different either way. That's true. Yeah, right. But accountable care, we need accountable care 2.0, clearly. Why would we think we got it right to begin with? This is so complex. We know we're going to get it wrong. It's time to adjust. It's time to make some significant adjustments to the way we're thinking about this. And I may be naive and excessively optimistic, but the difference between now and the 90s is that actually providers feel good about the accountable care work that's going on. It's not like the nastiness of gatekeeping and everything we had in the 90s. The providers feel good about this. They want to go there. Give me a reason to go there. The deal is so bad right now, it doesn't make sense to go there. SSP track 1 doesn't make sense to go there. Bundle payment, it's not a killer yet. Certainly, and that's why they're going mandatory, right? By the way, I just want to say we're doing a lot. We're next-gen ACO. We got 15 ACOs. We got 200,000 people. We got $500 million in bundle payment programs. So I'm not trying to tell you I don't want to do this. We are doing it, but most providers are not in a position to do it. So I'd say, Madam President, make accountable care a better deal. 80%, no upside risk sharing for a while. We forget the famous words of the individual who helped make the National Health Service a reality, and I cite that with great caution in the city, I guess, but nevertheless, who said, when asked, how did you make it work? How did you get the doctors to agree with this? He said, I stuffed their mouths with gold, right? He knew that he had to find a way to move people, to transform folks, and that was a key to success. And I think we need to make this path attractive. We could do it mandatory, but I don't think mandatory is the way to go. I think I'm optimistic, there's still a chance to engage our provider system in willingly embracing delivering triple aim care. So we've got to do that, which means we need to adjust the macro regs and allow folks to get into the alternative payment model track through track 1 or SSP track 1. I think we should have full waivers, but I don't think people should be allowed to stay in the program if they are not producing results. So give them 3, 4, 5 years. If they don't produce results, they're out. We need to make some technical adjustments to benchmarking approaches. I would say require OPM to ask all FEHBP participating plans to meet the Secretary's goal of being at 50% by 2018 and so on with alternative payment models. Do the same thing for TRICARE. Do it for DOD. Do it for the veteran system, for their outside components. Put the full force of the federal government behind spreading alternative payment models and require states to do it for their employees if they want to get 1115 waivers. So I would double down on these efforts to encourage the system more and more on a voluntary basis to transition into a new way of delivering care using these different financing models.
Marc.
So like my colleagues, I'm going to press that button that stops the elevator.
Don't any of you live in condos? I mean, like second floor?
Certainly, I would take the time to explain the need to engage the end user in the design of anything related to health. This is the only sector where we don't do that. I mean, how many people in the room have a smartphone? Raise your hand. Okay. Do you think they would even change the color, or even a single component of the functionality without doing extensive research on how it will impact the end user and whether or not the end user will buy that? We do not do that in health. We've made great progress on the innovation side, and I had the privilege of partnering on one of the innovation papers that will be discussed later. But the concept of patient input into the development of new interventions, whether they be biopharmaceuticals, devices, diagnostics, has been transformative. One of the ways we got the FDA to realize that they were missing a critical component of data was by requiring in the Prescription Drug User Fee Act number 5, a number of years ago, that they hold 20 meetings with disease areas with patients and family caregivers. And the goal was to understand the burden of disease and the burden of treatment. And what we saw in every single meeting was that folks from the FDA, folks from the biopharmaceutical sector walked away saying, what I thought was most important to the patient was wrong in every single instance. That meant that the targets we were shooting at to develop treatments were not focused on the issues that were most important to the patient. And that has transformed that sector, both here and globally. And we see companies ramping up to bring in the science of patient input into what they do. We see the regulators here and globally looking at how they're going to take this data and incorporate it into their benefit risk determinations, how they're going to incorporate it into labeling. Very specific example, you look at Duchenne's muscular dystrophy, horrific disease that impacts mostly boys, and at 3 or 4 they start to regress, and by the time they're 18 they're usually dead through a horrible, debilitating disease. Everybody thought what was most important to the parents and the children of that disease was, let's extend their lives by 3 months. You know what, you talk to the parents and you talk to the kids, and they'll tell you, 3 months of life where I can't breathe, I can't talk, I can't communicate, I can't move, that I'm afraid I'm going to choke to death in my sleep. That's not what I want. What I want is the ability to have enough strength to grab the sleeve on my arm and throw my hand onto the table and be able to walk up the screen of my iPad with my middle finger and my index finger and type out a message. Give me 3 more months' ability to do that. When you look at how we deliver care, you look at this award-winning journalist who wrote 2 books, one called Strong at the Broken Place. He chronicles in it, and he says, see me, hear me, listen to me. The vast majority of people with chronic diseases and disabilities are silent. You don't see them, and we certainly don't listen to them. We need to look at how we integrate their perspective in how we develop quality measures, delivery designs, even payment models, and how that plays out in optimizing what is truly most important to that population. My fundamental recommendation I would do is I would wed 2 of the papers, the democratization of health and the paper on workforce, which started to look at how you would segment health from people with acute care and injury, population health where we're trying to promote and maintain health through prevention. You look at people with complex chronic disease and end of life. I think you start to look at those 4 components, you start to look at the needs of those 4 components, and you engage the end users in how you design that. And then let's have a discussion about how we align the incentives. But let's stop having surrogates speak for the end user, assuming they understand what's important to the end user without engaging them. Key component to driving appropriate use of healthcare, eliminating a tremendous amount of waste that I know my population receives because the care is not aligned with our own circumstances or our own goals. It's our opportunity to really think differently. And if I were the president, given the challenges they're going to have and the opportunity to act in those first few months, I would go big or go home.
Lou.
Well, since I'm last, I'm going to keep my elevator speech shorter so I can react to a couple of things that others have said. I have 3 areas in my elevator speech. Number one, I think the next administration should launch a major initiative on data, quality measurement, and interoperability. It's essentially the IT infrastructure for doing everything that everybody has already mentioned. I'd ask them, where is our national dashboard for health system performance? We don't have one, and we should develop one. And one thing I would recommend the administration build off, NAM also had an initiative and a report called Vital Measures, a national dashboard core measure set focusing on both health and healthcare, and I think that there are a number of good recommendations in that. So start to build off of that. The related second recommendation builds off of Marc's comments. I think there needs to be a specific national initiative for collecting, analyzing, reporting data from the patient and family perspective. Patient-reported outcomes, patient-reported outcome measures, patient experience. We have CAPS, but that's about it. How does anybody going to know at scale the kind of questions that Marc has laid out for us? We don't. We can measure costs and prices. Not so bad. We've got work to do. We can measure quality. We still have work to do there, as I said. This is an area that's a huge gap. We don't have an infrastructure, and we could scale it with information technology, pinging people on their cell phones, short surveys, data mining of social media streams, and so on. So I think that's number 2. And the third builds off of Peter's comments. I would enlarge it a little bit. I think we need to modernize the Medicare program. I think that the way I think about it is that it would be great if the Medicare program acted like a 21st century plan benefit sponsor and used all the tools that are available to a modern benefit sponsor to drive improvement in system performance and the care of the people that they are responsible for. Payment is probably the lead dog, as you all know, a lot of work on payment. But plan sponsors use a lot of things besides payment. They use care management, they use data analytics, they use networks, they have different kinds of, they stratify the population in different ways. So I think there's a tremendous opportunity to take those tools and actually add them into traditional fee-for-service Medicare. And I agree with Peter, I think Medicare Advantage is a platform. It already has a lot of innovation. You have an accountable managed care entity. You have people that have voluntarily signed up for a particular different approach, and a lot of innovation within the care delivery in MA as well. So I think that could be why couldn't there be a special benefit program for high-cost, high-need patients that included community and social service, different benefit structure, those kinds of things. So that's my 3-part elevator speech. 2 quick comments on the other things. I think Peter mentioned mandatory payment reforms. I think there's a lot of potential there, but I think there are 2 things I would be cautious about mandating payment reforms. One is, I think my lived experience in payment reform in the private sector is that these things, you never get it right the first time. You have to basically continually iterate with your delivery system partners, and Rick may want to comment on it as well. And if you kind of mandate something, particularly from government, it tends to be a fixed design, slow to change. So that's a problem. And then the other one is you have to be careful about what incentives you're setting up holistically. And one of the challenges that I worry quite a bit about is the issue of provider consolidation, market concentration, and things like that. So those are things to be attentive to. And the other, on Rick's comment that we need to reform ACOs, I completely agree with that. He said sort of make it easier. My reaction is aim higher. And I agree that you have to allow time. It takes time. You know, the high-performing integrated group practices got that way over decades. So you have to allow time, but you have to aim higher as well. So I think I'm a little worried about sort of making it easier to play by having relatively modest impact. I think we should aim higher and give people the tools and support they need to succeed.
I suspect each of you would like the chance to comment on what some of the others of you have said, but let me, if I might, turn to our first question and then allow you each to sort of engage. And I want to begin in part where Lou left us, and that's on this question of high cost, high need. Marc touched on it as well. One of the papers, led by David Blumenthal, looks at this issue and looks at essentially what are the tools necessary? What is it that we need to do to be able to adjust a system to address the high cost, high need, taking into account the issues that Marc has raised about choice, about what the consumer or patient essentially wants to do. In the paper, they talk about some of the success stories. They talk about Denver Health as an example, and they talk about segmentation and the ability to, in fact, segment that population and to provide the services that are uniquely suited to that population. But the obvious question is, what do we need to know in order to do that? Do we, in fact, have the tools that allow us to do that today? And how might we move that forward? Mixed results in terms of what are identified as being the principal contributors that essentially create a high cost, high need, and how one might design a payment system. And we can build on this by talking about value-based payment and how you integrate that. Also transparency questions. What is it that we know? How good is the data and how valid? And can we act on that data? But what about the movement to try and create a unique set of circumstances for high cost, high need? What is it we need to do? What are the systems we need in place, and what data do we need? And I would ask Rick and Lou to start, but open it up.
I mean, the interesting thing is, the patients don't wear BPCI or ACO or, medical home identifiers, right? They're people that have their distinct and unique set of circumstances, conditions, and needs. And the reality is, I think for the last 10 years, those are the people that we have been targeting and trying to find ways to help them. And I think we've come a long way, as Marc said, to be more people-centered, to use techniques that seek to understand what's important to those patients. The interesting distinction, or the interesting reality of, on the payment side, if you look at bundle payments and you look at ACOs, the reality is, from the end you look at MA, those are the people, the 5% or fewer that we're talking about, that everyone is finding their way to. And HCC alone, not so good. I mean, the R-squared on most of our predictive modeling tools is less than 40% or 0.4, whatever. And that hasn't changed a lot, I don't think. But when you start factoring in, the closer you get to the identification and intervention, to the actual deliverer of care, I believe the better you are at understanding who it is you're after. But the reality on the payment side is, if you look at the work that was done in Massachusetts around bundle payment, I think it was Mathematica who did the work, or Rand, I'm not sure, I don't recall which it was now. The vast majority of savings were in people were in the chronic disease bundles, which are exactly these people, right? Which, hips and knees and, cardiac surgery, yeah, there's savings there, but the savings that everyone attributes to bundle payments in the abstract is for the same population that we're treating in the ACO world or in the medical home world. So to me, that's why it kind of makes sense to do more, take those folks in that population health space. And the key is not just what that patient needs, it's the reality of managing a set of people and a large population of people, some of whom will be in that category this year, but not next year. Some of whom will be falling, who aren't in it this year, but will be next year. And what you want is a system of care that rigorously looks for the opportunity to make a difference for any of those people. And that's why, to me, a population health approach is our best shot at getting it. We've got decent enough tools to do it, and we're getting better at intervening, and I think, and making a difference at this point.
Lou, how difficult is it to imagine or look beyond what we know to be medical services today and the current Medicare benefit, the point about whether we need to modernize the Medicare benefit, and that is to touch on those services that are not traditionally within our bucket, but in fact for the high-cost, high-need patient, whether it's care management, whether it's the non-traditional social welfare services. How difficult is it to imagine in a non-ACO world moving into a system where you, in fact, can accommodate that mix of things in order to target that population? And do we know enough about being able to segment? Can we identify easily who those people are and who will benefit most from what that difference in services might be?
Yeah, I think there's always opportunity to advance, but I think, and there's a number of different ways to configure it, but I think there's this is an area that deserves the focus, and I'm very happy there was a paper there. How many of you in the audience have ever heard the term ID strat? Anybody ever? That's sort of inside ID strat. Anybody? That's kind of inside lingo in my world, but that's number one. And that's shorthand for identification and stratification. You use your data and analytics to identify, as Rick said, kind of not only kind of what's the at-risk population, but at risk for what, and whether it's just sort of and it's a high-cost, high-need patient might just be somebody with hemophilia that has drug spend of $100,000 a year. That's very different than somebody with 5 different chronic conditions that interact with each other. And I guess my take, Sheila, is that there's sort of 3 general things you need to do to take care effectively of high-cost, high-need patients. First one is ID strat, identification and stratification, so you kind of understand them at a more granular level. Second, as Marc has said repeatedly, find out what their goals are. What is it that they actually want? Because they know, and we typically don't know as either payers or care delivery systems to the extent that we need to. And the third is to build, this was your question, make sure there's a supportive system that will allow them to meet their needs. And it's been an interesting experience with our ACO partners. We were very early and on this journey, as Rick knows, towards changing our payments within United Healthcare towards a value-based payment. We're on track. You know, if that became a mandate, that would be something we could handle, because we're basically have already said we're moving aggressively, just like HHS is, to value-based payment. But the ACOs that we have been working with is interesting. As they get going, they first, kind of do the basics, and then they say, oh yeah, we've got this high-need, high-cost population, and there's one group that kind of is a medical, their issues are medical, and they know how to deal with this population. But what they've been telling me, there's another group, they say, yeah, their issues are not, they're kind of this combination of medical and social, and they may have comorbid physical illness and mental illness, and they're in distressed family. Their family is rather chaotic, and they're in a very chaotic, difficult geographic area for us, and we know they need stuff in the community. We're not quite sure how to pull it together. That's the conversation I've been having for about the last year or so with ACO collaborators. So I think that's an opportunity to kind of extend the medical model beyond the ACO, but not to medicalize it. I think this is a good example of new relationships that need to be developed.
Mm-hmm. Peter?
So I guess a couple things. One is a little bit of caution. I mean, we're getting better, but even simple problems like predicting, or what should be simple problems, like predicting who's at highest risk of being readmitted to the hospital, we have done a terrible job at historically, even with on-the-ground knowledge, going out and asking the nurses. And that problem, there's been progress on, but it's still, not perfect fidelity, nothing close to it in terms of predictability. And that highlights one of the issues, which is if you can identify the people at highest risk, just to focus on that problem to start with, it's not rocket science. You make sure they take their medication, you make sure they show up for their doctor's appointments, you address other issues that might be involved in the social environment, and you can dramatically reduce the readmission risk. But we can't afford to do that for absolutely everyone. So without very precise stratification, the whole endeavor kind of becomes quite complicated. And actually, this highlights one other theme that I think is worth highlighting, which is the dominant role of post-acute in Medicare in particular. The Institute of Medicine study on the variation across the United States showed vastly disproportionate to its share of current spend, that post-acute variation explained 3/4 of the variation in Medicare spending. I mean, it's unbelievable. And it's related, and there's overlap. It's not perfect overlap, but there's overlap between that issue and the high-cost patients, because the question is, where is the value in that particular SNF, in that particular IRF, what have you? There seems to be a lot there that is worthy of further attention.
Two thoughts to this.
Yeah, Marc.
So understand the identification of where you draw that line are critically important. But at the end of the day, you have a very small percent of the population driving a huge amount of costs. And to the extent we can identify those and then get outside of our medical box, because it's only a short and intermittent piece of what's causing these challenges. I worked with the medical system in a state not too far away, and there was a really classic example of a woman who had been in the emergency room 77 times in 9 months. Think about that, and think about the cost. They kept trying to throw health care at her in a way that would optimize her health. The reality was, when you sat down with this person and you went to their home, this was an elderly woman who lived alone with limited support, who every time she went out of her home to get food or services would find it almost impossibly to climb the front steps to her house. And she'd end up sitting on the steps until an ambulance would take her to the hospital. Now, that makes no sense. And we see countless examples with people with complex chronic conditions that are finding themselves in the healthcare system at extraordinary costs because we're not addressing the social circumstances we find them in. Here's an opportunity for us to start to look at how do we bundle our payments that go beyond our medical services and into our social services. You see in the UK and other places where they're using social impact investing. And they're using models where you actually look at an intervention for this population, and if you can achieve a cost savings to the medical and social services department, you receive your money back, and it's financed by people who are looking to do good with their wealth and investment. I think we have to start to get outside of our box and look at new opportunities to address this population in particular, because they are driving the costs, and we're approaching them as if they were a medical set of circumstances, when in reality, what's causing so many of these problems are very, very different. And I see a lot of models, but we've not incentivized this so that you guys can do this well, because it's focused in on the medical interventions. I think we have to take it a step further.
Let's turn to some other elements that were touched on in the papers but are relevant to all these issues. Value-based insurance design. The desire to essentially move to a system where there is a payment that's linked to value. It assumes that the patient has enough information to make choices. It assumes that providers are incentivized to essentially participate in those programs. We've not yet seen a great deal of return. We are learning. No cost reduction guaranteed in this environment. But I'm interested, one, in what do we think the steps are that are necessary to move to a value-based payment system? Also, what kind of information, what kind of transparency, what will in fact encourage and allow individuals to make a choice of their providers, of the site of location, and so forth. So where are we in terms of value-based?
Well, I'll start. I think I sit on the advisory group for the University of Michigan Center for Value-Based Insurance Design. I think it's an extremely important, and as I think in the paper, the term that they like to use, it's in the paper, of clinically nuanced, that we could tailor and have more clinically new, as a clinician myself, that just makes a lot of intuitive sense. I think the issues are around many of the things, Sheila, that you outlined, sort of easier said than done, I guess, is sort of the issue, and requires more infrastructure than I think in many cases we currently have available. But there's also a bit, Rick used the term mindset, there's a mindset issue too. There's also currently a bit of asymmetry in the application where it tends to be applied to say, let's lower the cost sharing, lower the financial barrier to high value services. But if you really want to create a high value system, you ought to also have some work on the other side to raise the costs and have for things that are low value, that is politically more difficult, operationally more difficult, because one of the challenges of a lot of high value services tend to be preventive services that apply pretty generally to the whole population. The problem with low value services conceptually is that in aggregate a service may be low value, but there's a population that service is exactly the right thing and it's a high value service. So you have to really, this is sort of the delivery system analog of precision medicine in my mind. You need to be much more precise about how you do things in order to work on that side of it. But there are some things you can do. Reference pricing is one that essentially, if you had it not so difficult that you create too much of a financial barrier, but you essentially say, look, everybody has coverage for a service at a reference price, and if somebody wants to make choices above and beyond that, that's up to them. So I think it's very promising, the idea of clinical nuance, but if we really were going to go after it in a big way, we would need more precision and more infrastructure than we currently have, particularly on using benefit design to deal with low value services.
Other comments? In that same vein, touching on this question of how you incentivize patients to make choices and what kind of information they need, there's been a lot of criticism of the sheer magnitude of the number of measures that are used, that the confusion as to which of them are valid, which of them accurately predict or in fact evaluate the services that are provided, whether or not there's risk in terms of information and how it's provided and to whom it's provided. Where are we in terms of the measure of what is value, what is quality, and how do we in fact utilize that information? There was a suggestion of moving to a standard, essentially establishing a board that essentially agrees upon what those measures ought to be. We hear from providers the complaint about the sheer magnitude of private payers, public payers, all demanding different data in different forms for different purposes. Where are we in terms of moving towards being able to measure, being able to report, and being able to allow the families and consumers to use the information in a way that they are informed and essentially not discouraged from doing the right kinds of things?
I think we've made progress, but it's fraught with difficulties. And one of the things I guess I came away from my limited 3-year stint in federal service with the belief that you need to be careful about going too deep with metrics at the government level for the reasons that Lou mentioned earlier. If you start, the more you mandate, the more you fix things, it's very hard to change things, and then people respond. And I think the whole issue of pain management and where we went with metrics around pain management really raised the question of were we in effect enabling and I don't mean this as a criticism of anybody at CMS or elsewhere, but it's the industry. We were pulled into a world of saying pain is the 5th vital sign and we have to do everything to manage pain, and we suddenly find ourselves 10, 15 years later in an opioid epidemic. It's not an accident. There's a step-by-step process that occurred. And so I think we have to be careful, and our position has been to urge CMS and other payers to go up. And yes, we need to be demonstrating satisfaction and that we're doing a great job for patients, but not going down into 6 different varieties of that, because what happens is you get distortions in the actual delivery of care, so that my daughter coming out of a hospital right up the street from here, got asked much more instruction as to how to take Percocet than she did breastfeed. Twice. Postpartum. Like, that is, to me, a very visible example of how we have to be cautious and kind of humble here in DC and think about, let's stay high level, let's not create deep distortions, but let's get meaningful information. You know, you'd like to think the patient-reported outcome measures are going to make a difference. Hopefully we'll get some experience of that with the mandatory bundles. But let's keep it high level, and I don't think we still don't have a mechanism, I don't think, for actually pulling together the relevant audiences to develop a kind of national, simple, high-level metric kind of approach that people could use as a standard way of thinking about care.
I mean, this is a natural place to ask the question of the balance between the public and private sectors, and whether or not this is an instance where, in fact, the feds need to step in and establish essentially a standard, and everyone's held to the standard in terms of what's measured. Then the question becomes one of reporting. Is public reporting efficient? Is it effective? Is there risk in public reporting in terms of how people utilize the information? I mean, we remember the sort of first go at, you know, publicly reporting some of the data on hospitals. And the hue and cry that they didn't do correct risk adjustment, that they didn't reflect essentially the nature of the patient mix. I mean, is this something where the federal government ought to take the lead and essentially standardize? And where, in fact, are the risks in terms of public reporting and how people use that information?
Well, I think this whole area has moved from one where the focus was essentially on development of standards for specific measures and just having them out there available to use. This is something the work that the NQF, I'm on the board of NQF, has done for many years, done it well. But now the stakes are higher, and I think we're now talking at a very different level, essentially about a measurement system. And I think the transparency paper in the series focuses on the needs for standards for kind of the measurement enterprise, which I think is critical. And I don't think there's any question that there's a role for government in building out the infrastructure and the investment needed to have a robust measurement system for the country. People may debate about whether the government ought to specify specific quality measures, but I do think, also building on Rick's comments, I do think keeping it higher level for the purposes of kind of accountability and moving more towards measure harmonization is an important direction. That this kind of everyone doing their own thing, and even every federal program having their own thing, the federal government has worked hard to try and align what they're doing. I'm part of a core measure collaborative that's working both with public and private sector to do the same thing. So that alignment and harmonization is critical. But having said that, we also have measure gaps that have to be filled. There are things that are important to measure that we actually don't have measures for. So I think there needs to be further investment in that as well.
Well, certainly MACRA moves us towards a high value being placed on data analysis at the individual level, and whether or not, in fact, we're in a position to do that. I'm interested in Rick's thoughts as to whether we're ready to move quickly in that direction, how reliable and valid the data is, or whether we're going to get into the same situation we've had in the past.
Yeah, I mean, to measure quality metrics at the individual, small group level is just, you know, not terribly meaningful, I think, in terms of reporting. But my concern about MACRA is that originally the purpose of MACRA was to drive people into accountable care entities, and then we put up an obstacle to them getting into acceptable accountable care entities. So now we end up creating the potential for a diversion into a backwater of old style reporting on value, I think. So to me, that's one of the key things I would stress to the new president, that it's important to see if we can't open the door to get people not have a giant MIPS side of macro, but have folks get into that other side. Just one other point, 2 points on the value-based insurance design. It's happening. I got to tell you, man, we're worried about being in narrow networks and, you know, adjusting a price and taking some risk in the commercial side. I mean, that's happening. It's real, and we all know what people are buying. They're buying cheap products, right? They're buying the lower end of products on the exchanges. So, you know, stuff's happening. Let's be patient. You know, it's happening. The world's evolving. We're coming up with new models, new networks, et cetera. And then let's talk and let's fight back on, you know, on fixing that problem on the backs of the same old people, the lower people in the lower end of the income distribution, by saying they got a $1,500, $2,000 deductible. You know, there's lots of ways of engaging people and thinking about the cost of care without making people forego essential services.
Underinsure.
And underinsure them, yeah. So I think that's a real challenge for us.
Yeah, 2 thoughts around this. First of all, value has been defined by virtually every stakeholder in the system for specific purposes except the patient. And when you look at the frameworks that have been developed, they've largely been developed without input from the patient community. And so we have been working with them and actually developed a value model rubric that looks at the different stages of framework development and 6 domains that are important to people with complex chronic conditions to help them identify what is value and how you would engage in a low-touch, high-touch way, and how you would use that data to make it patient-centered. Part of the challenge and part of the reason why people routinely ignore any information about quality when they're making their decisions is we're not providing them the information that's relevant to them. And until we start to look at what is truly relevant to the end user, they're not going to use these tools. You look at a population that is trying to make informed decisions, but we don't have that. When you look at the focus on low-cost products, you're absolutely correct. And we see that even amongst people with complex chronic conditions that have to select a product that's going to get them to the providers they need to see, the specialists, the medicines, interventions they need. But the data isn't there for them to make an informed decision. And that is really, really challenging. We have a lot of opportunities, but you got to look at what is quality to the end user, what is value to the end user, and then if you define that in partnership, in co-design metrics with the population, then you get information that's useful for people to actually take notice of.
Peter, I know you want to comment, and when you're done with your comment, I want to turn to another topic I'd like you to begin on, and that is, in this context of how you incentivize certain kinds of behavior, the use of the tax code, and how we essentially utilize that today to support certain behaviors in terms of purchasing and design. But
sure. So first, just on the comment I was going to make is I agree with the other comments that have been made already. But a note of optimism here. For a long time, economists complained about the nature of our insurance system in providing deep third-party insurance against even mundane, routine things. What's been happening is deductibles have been going up. That everyone knows about. What I think people haven't appreciated is at the same time, the out-of-pocket share, not only for national health expenditures, but even within employer-sponsored insurance itself, has not increased. That is to say, you read a lot about increased cost sharing, but if you look at the numbers, total out-of-pocket spending divided by total employer-sponsored insurance basically is flat. And the reason for that is that a decade ago, something like 1/5 of coverage, at least single employee coverage, through employers had no out-of-pocket limit whatsoever. Today, that share is basically 0. And precisely because healthcare costs are so concentrated, as we already discussed, that seems to be balancing the fact that deductibles are going up. So for most people, the higher deductibles matter, but for most dollars, that better protection against out-of-pocket expenses, extreme out-of-pocket expenses, seems to be balancing it. And that's kind of sort of the right, I mean, with the caveat that the deductibles discourage some mundane care or low cost care that is valuable, that kind of is the right insurance design from sort of economic efficiency. You want more cost sharing at low levels, and then you want the catastrophic coverage. And we've been evolving that way without people really paying attention. So that's the first point. The second point is, what about the tax system? I think so many things have actually gone much better than expected over the past 5 or 6 years. If I had stood up in this auditorium 7 years ago and said, I think real per person spending in Medicare will fall for 6 years in a row, everyone in the audience would have laughed. But that's exactly what's happened. The one thing that's unfortunate, in my opinion, that we've done to the one significant modification to the ACA beyond the medical device tax, which I think was unfortunate also, was delaying the Cadillac tax, because I think the 2-year delay is going to kill it. I think this is the new SGR. It's never going to take effect. And the reason that this matters is the Cadillac tax, everyone thought was intended to somehow penalize either the unions or the high-cost plans. It was really intended to provide a strong incentive for employers to search for a more efficient plan design and avoid having the tax trigger. In fact, many people don't appreciate the majority of the revenue that the Congressional Budget Office projected would be raised by the Cadillac tax was not actually raised by collecting the tax. It instead arose because the CBO assumed that employers would shift their plans to a less costly version, and the result of that would then be a different mix of take-home pay versus health insurance in labor compensation, and that's where 2/3 of the revenue came from. By delaying that and effectively killing it, I think we took a lot of the pressure on employers, and they haven't fully kind of appreciated it yet, and some people are still pretending that the 2-year delay will just be a 2-year delay. But once it's fully appreciated that thing is dead, I think a lot of the pressure that employers that has been imposed on employers to start seeking out better designed plans, including the value-based insurance stuff, I think that's going to attenuate in an unfortunate way.